guys, Dr. Chad here for another interesting case. This time we're going to be talking about a very common disease process in the elderly, lumbar spinal stenosis. Jokingly in medicine, we call this the little old lady pushing the buggy syndrome. What we mean by that is spinal stenosis, just to show you the anatomy before we look at the imaging, means that the spinal canal where I have my finger inserted is becoming clogged. So think about our cars. Over the years, a car has multiple wear and tear, the engine goes and it builds up gunk. Same thing happens to our spine of the years of walking, lifting, working, you name it. These ligaments grow, and when they grow at a certain point, they completely obliterate the spinal canal, making it difficult for the nerves to exit to things below, as well as the legs. The reason why we call it little lady pushing the buggy syndrome is the symptom from spinal stenosis is what we call neurogenic claudication, meaning when I stand up straight and I walk, I get kind of a cramping and aching in my legs because the nerves in my spine are being compressed, causing those symptoms. So if I lean forward, if I push on that buggy, by leaning forward, I open up some of these areas and it relieves the symptoms. When we look at the imaging, this is a very classic picture of spinal stenosis. This is, again, a T2 sagittal looking from the side. This would be the butt, the front side, bone disc. These gray lines are the nerves coming down. The white is the spinal fluid. And you can clearly see, think about a pipe. There's the clog. And you can see that basically it's amazing how this system's built, that nerves can get beyond something that clogged. This is growth of the ligament, and there are the disc pathologies. So the two together is causing a very tight, moderate to severe stenosis. This is L3, L4, and L5. When patients have this at this level, the simple things usually don't work. I mean, obviously we start physical therapy, exercise, those type of things. You can do steroid injections in these areas, and that can sometimes be helpful in milder cases. But eventually, as the gunk builds up, something has to be done either to remove it or to open it up so the neurological structures can go through. There's a new commercially available minimally invasive procedure called Vertiflex. And what Vertiflex is they insert this little surgical hardware in between these two bones, which is called the spinous process. And by inserting it, you can see that it opens up the foramen and it opens up this interlaminar space, giving some decompression of those segments. The nice thing about Vertiflex, it's simple, it's easy. You're not removing any bone, you're not removing any ligaments. And if you look at the studies, they have some very good evidence that this can relieve a lot of the neurogenic claudication, which is associated with spinal stenosis. The limitation of Vertiflex depends on the anatomy. If you have terrible arthritis, if the stenosis has advanced to a severe part, this little invasive procedure is not going to be enough to decompress this. Then you would go on to see a spine surgeon, and what a spine surgeon would do would remove the lamina as well as that ligament back here. So basically pop the top, a decompressive procedure to significantly reduce the spinal stenosis. That is the gold standard in medicine. This represents a less invasive option, but again, the gold standard would be to completely remove these segments. The downside of that is God put everything in here for a reason. So when you start removing things, you can have facet pain, you can have complications from surgery, you can have other things that develop by removing those structures. What I always tell my patients when I sit with them, if the pathology is severe as this, then I usually don't recommend a Vertiflex. I would tell them to go on and just have the decompression. If they're on the fence, I kind of leave it up to them and say, if you want to try this, the invasiveness is very minimum, the risk is very minimum, but just understand that if this doesn't work, you have to go on and see the neurosurgeon anyway and get that procedure done. So it just depends on the patient of whether or not they want to take the chance on the less invasive procedure or whether or not they want to just go forward and get what has been the gold standard in medicine for many years. But again, my job is to educate them as to the pros and cons of both and ultimately allow the patient and their family to make an educated decision. So again, spinal stenosis, very common in our patient population. Always think about that neurogenic claudication. It's very different than vascular claudication. So when they rest, it usually goes away, as opposed to a vascular claudication where as long as they're needing blood into the calf, they have the same type of cramping symptoms. So it's not as associated with walking as you do with the lumbar spinal stenosis. I hope this was helpful. If you think you may have spinal stenosis or you've been told you have spinal stenosis, please come see me. I'm happy to review your imaging. I'm happy to go through multiple procedures, different options as we have done here today, and hopefully find the right physician and the right procedures that best fit you for your disease process. As always, thanks for tuning in, guys. Any questions, please interact with me on social media. Happy to answer anything, and I'll see you next time. Take care.